Hi everyone, it's Dr. Sloan, and we're going to review drugs for coagulation disorders. So remember that hemostasis stands for blood stoppage. And there are some reasons that we clearly want to not bleed, but there are also some reasons why it might be better if we didn't clot so easily. And so we talked about those pros and cons, right? So the pros would be, that we could maybe use of anticoagulation would be that maybe we could prevent a clot from forming, like a stroke, that we could prevent an MI. Or that we could prevent even a DVT, which is great. But at the same time, the cons of coagulation, even though we think of the pros of coagulation as not bleeding, the cons are, again, this production of a clot or production of a blockage. So we're going to talk about this and kind of how we can use drugs to sort of exploit these different mechanisms of clotting. So signs and symptoms of bleeding. We can't talk about any of the drugs that affect clotting unless we talk about bleeding. And again, you need to know these because your patient may not tell you they are bleeding. They might tell you that they're bruising or that their gums bleed when they're brushing their teeth, or that their urine's pink or has little clots in it, but they're probably not going to tie their headache with bleeding or their lack of energy, maybe from a decreased hemoglobin hematocrit. So you need to look at these signs and symptoms of bleeding and be aware that there are some things that we can't see, right? We can't observe, but that we can be on the lookout for through various tests or various complaints to tell us if someone's bleeding. So the clotting cascade, I really don't need you to know anything more elaborate about it than the fact that it occurs, okay? That there's some kind of an injury, there's a vessel spasm, the platelets become sticky, they put out a call for more platelets, like, hey, we need help over here. The clotting cascade is initiated, thrombin, fibrin occurs, and a fibrin web is kind of thrown over that little platelet clot, and together the fibrin and the platelets make a clot. So clotting factors are made in the liver. So people who have hepatic impairment, either due to disease or potentially due to alcoholism, which is a disease, may have abnormal coagulations. They may have coag problems just because of their liver, but for sure we want to be aware that the health of the liver plays a role in whether or not patients can engage in normal coagulation or not. And then vitamin K, which is produced by bacteria in the large intestine, is required to make some clotting factors. So if your patient has absorption issues, perhaps they have an autoimmune disease that affects the intestine, like Crohn's or ulcerative colitis, they may not make as much vitamin K. And that's something that is needed in order to make clotting factors. So again, here's the clotting cascade. This is in your book, and it's very simplified. You have an injured vessel, you have platelets and damaged cells that try to block the hole and call out like, hey guys, we need more platelets. Factor X is then stimulated, prothrombin activator is created, and now the liver's going to release prothrombin and fibrinogen. And prothrombin is going to make thrombin. Thrombin is going to convert fibrinogen into fibrin. Okay, so, and this is what we're going to get as a result. We're going to get this beautiful clot with platelets and fibrin and maybe a few other little like unexpected dead cells from the injury. We might have white blood cells in there, but in general, it's fibrin and platelets. Okay. So then we talked about what is the difference between a thrombus and an embolus, because you hear both terms, and we don't have two different terms if they mean the same thing. So a thrombus is a clot that usually forms in leg veins, although you can have a thrombus anywhere. It can also form in the atria during atrial fibrillation. It could also form in an implanted catheter, an artificial valve. It could happen with post-op immobility or post-op site, right? Like perhaps like a knee replacement or a hip replacement where they're putting in a piece of implanted equipment into the body. Those things all put us at risk for a thrombus. But remember, a thrombus is just a clot that is stationary. It is fixed to something and it stays there. However, if it gets dislodged or through other mechanisms in the body, the clot moves, now it becomes an embolus. And so it's a clot. We talk about throwing the clot. This is kind of a thrown clot, a clot that gets moved. And now it can travel and go somewhere else and get stuck. And oftentimes we'll see a pulmonary embolism. Those clots usually start in the legs. They go up through the venous vasculature, up through the vena cava, into the right side of the heart, and then goes right to the lungs where it gets stuck in all that little teeny tiny vasculature in there where oxygen and CO2 are supposed to be trading places, right? It can also happen that it can get a clot that's in the heart that can cause a cerebrovascular accident, CVA, better known as a stroke. Okay, so maybe you have AFib and your atria is quivering and it's got a little clot in there, and eventually the heart does a nice big squeeze and pushes that clot out through the aorta, and it goes out, and the very first vessels that branch off the aorta go right to the head, and so we get a CVA. Or we can have an MI, which is, again, the vasculature that feeds the heart actually gets the clot stuck there, and now we've cut off blood to a piece of the heart muscle. The big problem with thrombi and emboli is that ultimately we're worried about tissue ischemia, meaning tissues that don't get enough blood, and then the resulting tissue death that occurs as a result of that. Okay, so we have drugs that modify coagulation, and there's two main types that I want you to learn. One is anticoagulants, and the other is antiplatelets. Now, in anticoagulants, we have heparin, and I apologize, I'm just now seeing that I need actually a third bullet under this. So we have heparin, which is short-acting. We have heparin, which is long-acting, which is probably what you'll be more familiar with. Enoxaparin, it's better known as Lovenox, low molecular weight heparin. And then our third drug, so this should be the third bullet right here, is Warfarin, commonly called Coumadin. Okay, so 3 anticoagulant drugs, 2 antiplatelet drugs. The antiplatelet drugs, they actually inhibit platelet action to prevent clot formation. And this often has to do with how sticky the platelets are. So remember, in a normal clot, the platelets are sticky and stick together, and then fibrin comes and lays a web over the top. Well, we can keep those platelets from sticking together by making them slippery. We can do that by giving aspirin. That's interesting. And then clopidogrel, which is Plavix, and this is an ADP inhibitor. We'll talk more about this. Think about aspirin. You guys have learned it as a pain medicine or an anti-inflammatory, right? But you do know that it's a non-selective COX inhibitor, which is great. It inhibits inflammation, but on the other side of things, it inhibits the nice platelet protection that we get from prostaglandins. So when you give aspirin, your platelets are going to become more slippery and you're more at risk for bleeding. So anticoagulant therapy is primarily directed at venous clots. Now we're going to talk about arterial clots as well, but we're going to start by talking about heparins. So two kinds of heparin that we're going to learn about here. There's heparin, which is short-acting. That's your prototype. It's given immediately, IV immediately, to prevent further clot formation. And again, this is if needed. If we're worried that more clots could be formed, if we think we have a clot maker somewhere in the body, then we might use this. It's an indirect thrombin inhibitor, so that is its action, right? And it starts acting immediately. But heparin regular heparin has to be measured. Its effect has to be measured by using the APTT, which is the activated partial thromboplastin time. And in order for it to be considered, for a patient to be considered properly anticoagulated, their APTT should be 2 times whatever the client's baseline is. And that's where we say, okay, now they're properly therapeutically anticoagulated. But the drug we probably use more is enoxaparin, Lovenox. And again, this is a low molecular weight heparin. This can be given sub-Q. It also acts immediately, onset of action within about an hour, but has a long duration of action. It works for 12 hours. And it pretty much provides consistent drug levels within most patients and anticoagulation, so we don't need to monitor this drug with labs. So, and I have the question here, how often do you think this drug is given? If its duration of action is 12 hours, it's going to be given every 12 hours if we want 24-hour coverage, which we do. The antidote for heparins is protamine sulfate. So if a patient gets too much heparin, and I think I told you a story in class about some babies that got very, very high dose heparin that caused them to bleed, the antidote that we would give to stop that anticoagulation is protamine sulfate. Heparin has a black box warning. And so epidural or spinal hematomas, which are like little tiny blood clots or little bruises, may occur while on heparin. Okay, so epidural or spinal, that means in the CNS, in the central nervous system. And it requires frequent monitoring assessment needed for patients with spinal anesthesia or a lumbar puncture who are on heparin. It can cause paralysis and death. So if your patient needs to have spinal anesthesia or a lumbar puncture and they are on heparin, this is something that you're going to want to make absolutely certain that the doc knows, the anesthesiologist knows, that people are aware and that they're doing it with eyes wide open and are aware of the risks. So why heparin versus enoxaparin or Lovenox? Why do we have both? Well, first of all, once upon a time, this drug did not exist. And so as old nurses in the old days, we only used heparin, okay? But once low molecular weight heparin was created, then this became kind of more of our go-to. Now, let's just say that a patient is at home and they're on Lovenox. Maybe they actually are now transitioned all the way over to Warfarin, and they're only taking Warfarin, but they find out they have to have a surgery. Well, Warfarin takes a long time to work, and it takes a long time to get out of the system. So we might switch a patient over to heparin and use heparin kind of as a bridge, right? So we'd have the patient on warfarin. They'd go they'd stop taking their warfarin and go to heparin, and then slowly decrease the heparin dose. Then we can do surgery, right? Heparin doesn't last very long, so we can do surgery. Then we can start them back on heparin and slowly begin their anticoagulation again. So it's kind of tricky, but it is something that is used all the time. It's a bridge that gets used between, full anticoagulation and then reversing that so that we can do surgery or procedure and then getting people back into that anticoagulated state. So the other anticoagulant therapy that sort of falls in the same family as heparin and Lovenox is warfarin. And actually, this warfarin should be all lowercase. It is the generic, and Coumadin is the brand. It is an anticoagulant. It is a vitamin K antagonist. Okay, so that's a little bit different than heparin. But the goal is to prevent stroke, DVT, and pulmonary embolism. And it may be given to prevent clotting events in high-risk patients following an MI or an AFib episode. So again, patients may be placed on warfarin. So the problem is warfarin also has a black box warning. All these bleeding drugs have black box warnings. Warfarin can cause life-threatening or fatal bleeding. Surprise. And regular monitoring of INR is required, the International Normalized Ratio. And patient teaching is critical. So INRs have to be checked on the regular if a patient is going to take warfarin for a long period of time. And most patients end up taking warfarin for at least 6 months and can take it for even longer. So contraindications. Obviously, we don't want to give this to someone who is at risk for bleeding or who recently had an event that makes them prone to bleeding. So things like trauma, active internal bleeding, bleeding disorders, intracranial means inside your head, hemorrhage, severe hypertension, or severe liver or kidney disease should probably not be taking warfarin. And this drug is started at the same time as heparin. We talked about this. This drug prevents the formation of new clots. So does heparin. None of the drugs we've talked about yet do anything to help the existing clot. So if a patient had DVT that turned into pulmonary embolism, the way they're going to get rid of that pulmonary embolism is their body. Their body's going to break it down, recognizes it as foreign or as not normal, and breaks it down. But the problem with, that is that what we're worried about is the formation of new clots. If we have a clot generator somewhere, again, sometimes people tend to have a lot of DVTs. Could be due to genetic factors or other things that make them prone to be kind of clot-making machines. Then we want to make sure that we have them as anticoagulated as we can. We have them so that they can not make more clots. So when we do anticoagulation for someone, let's say someone who's had a PE, we're going to put them on both Lovenox and Coumadin or warfarin at the same time. And the reason is that even though you're giving the warfarin, it takes 3 to 5 days for that to even work. So we don't want to wait for 3 to 5 days for anticoagulation to start because the patient could begin making clots. So we give heparin to start. Remember, that starts working within an hour. So we give heparin and we give Coumadin. So for the first 3 to 5 days, the heparin's doing its job. And as the Coumadin dose begins to get up to therapeutic levels in the blood, then we can take away the heparin and just leave the Coumadin. So while patients are on Warfarin or Coumadin, they need to be having their INR checked. It's not related to the Lovenox, it's really related to the Warfarin. So again, they're going to have their INR, which is a ratio of the patient's PT to a control PT. And the goal should be 2 to 3 times, meaning it should be 2 to 3 times above normal. So 2 to 3 times, if your PT is normally 1, this ratio should be 2 to 3 times higher than what we normally have. And that's good. We want that because that means our patient is therapeutically anticoagulated. Okay, so INR is going to be measured daily until stable and then weekly or monthly. And it really depends on how well the patient does with following all of the instruction that needs to occur when they're on this drug as well, which we'll get to. And the antidote for this is vitamin K, because this medicine inhibits the action of vitamin K, right? So we would stop giving if we had somebody who was way over anticoagulated or bleeding profusely, we would stop this drug, we would give vitamin K, and hopefully that vitamin K would assist in clot making and get our patient back to a healthy place. Antiplatelet therapy is used mostly for the prevention of arterial clots. And again, for this intro class, we don't need to go into the deep, dark specifics, but you'll kind of wonder, like, why are they on aspirin or clopidogrel instead of warfarin or heparin? So antiplatelet therapy, again, directed at preventing arterial clots, things that tend to form on the left side of the heart and get sent to the brain, okay? So, or to the heart. So aspirin is one. It's a non-selective COX inhibitor and makes your platelets slippery and works well. And it's very inexpensive. It can be purchased over the counter. Now, clopidogrel or Plavix is much more expensive, and it is an ADP receptor blocker, this adenosine phosphate receptor blocker. Now, it's much more expensive, and it's usually given to people who can't take aspirin. The thing is that aspirin and clopidogrel, aspirin can stay in the system for up to 7 days. Clopidogrel is a little bit shorter than aspirin, so that's good. You might want to look and see, are there antidotes or rescue drugs for this? And there actually is no rescue drug for aspirin. So if a patient's on aspirin, they're in a car accident, they need surgery, they're going to have to do it anyway, even with aspirin on board, because there's nothing we can do at that point to change the slipperiness of their platelets. That train's already left the station. So probably going to have to give this patient intraoperative platelets in order to help them with clotting if they have bleeding problems. So clopidogrel, Plavix is like platelets, right? And dog is in the word clopidogrel. So that's how I remember that and remember the brand name Plavix and PLA and PLA. Okay, so clopidogrel or Plavix is an antiplatelet drug. We talked about it being an ADP receptor blocker. And it reduces the rate of MI or stroke. It's given to prevent thrombi and coronary stents. So sometimes you'll hear people say, oh, grandpa had a heart attack. They had to put in 3 stents. And we talked about those a little bit. Those are like little straws almost that get placed, little tubes that get placed inside of arteries that feed the heart muscle, and they open up and provide kind of a way for blood to flow through what would have been a clogged artery. Those patients need to be on an anticoagulant, an antiplatelet drug, because those stents put them at risk for clot formation. So you don't want to crush these pills or tablets. They're generally well tolerated, and you can imagine that you might have bruising on this kind of a drug. The black box warning on this drug is that some people are poor metabolizers, meaning the drug won't be effective for them. And so more than 50% of Asians have genetic variants that inhibit clopidogrel metabolism. And actually, there was a lawsuit in Hawaii based on this drug because it was being marketed over there, and patients were asking about it, and then physicians were saying, this isn't a good drug for you, it won't work. And so it was actually taken to court. I think that's really an interesting kind of outcome with this. So we have to be aware of those genetic differences that occur across various populations, because we don't want to prescribe or advocate for a drug that a patient can't get. We are not prescribers as nurses, but we again can advocate for our patient. And then contraindications, obviously we're not going to give this to anyone with active bleeding. So here's just some ways to memorize heparin and warfarin based on their suffix. And I think that's helpful. INR is also in warfarin, right? RIN, INR, so you know that INR is the test that we use to regulate warfarin. So the most important labs that you need to know for these drugs, because these drugs must be monitored for safety. They have a narrow therapeutic range. And so we can't just give them and hope for the best, right? We have to give them, and then we need to be very careful in monitoring their effectiveness using these labs. So if someone's going to go on heparin, not low molecular weight heparin, but regular heparin, then we would be looking at an APTT, activated partial thromboplastin time. And that test basically measures how long it takes your blood to clot. So normal is 21 to 35 seconds. So when on heparin, it should be 1.5 to 2.5 times the normal value. Okay. And then we would also look at platelet count with heparin. But let's be clear, it's not because heparin affects platelets, because it does not. It affects clotting factors. But remember that there is a potential side effect called heparin-induced thrombocytopenia. So if someone is on heparin, we need to measure their platelets, their thrombocytes, by doing a platelet count and making sure that they haven't developed this kind of autoimmune problem as a result of getting heparin. We'll talk about that more. So then once the patient has transitioned and they're on warfarin, what's going to be looked at is the INR, okay? The International Normalized Ratio, which is just a ratio of patient's PT to a control PT, and it takes into account different testing measurements, chemicals, reagents, different labs use different things. So the normal INR when you're not on warfarin is 1, and a therapeutic INR on warfarin is 2 to 3. Okay. So again, you'll also hear sometimes when you're talking about all of these labs, you'll hear something like a bleeding time. Bleeding times aren't done very often. And it's actually kind of a weird thing where they actually make a little cut in your body and they look to see how long it takes for your blood to clot. and stop bleeding. And it's usually a diagnostic test that's used to diagnose someone with bleeding issues that are not explained otherwise. Okay, HIT. HIT is heparin-induced thrombocytopenia. It is an immune-related thrombocytopenia that is triggered by heparin. So heparin somehow triggers our immune system to attack platelets, which is really odd, but this is a well-known phenomenon. So the RN needs to check platelet counts before heparin administration. So you need to check and see if platelets are half of what they were the previous day. Hold medication and call the MD. Okay. Platelet counts less than 100,000, and you want to hold the medication and call the MD. What's interesting about this is you would think with thrombocytopenia that they do not have enough platelets and therefore they're at risk for bleeding, but actually this increases the risk for clotting, and it can cause catastrophic arterial and venous thrombosis. We're not going to go into all the pathophys of that because that would probably give us all a big headache. If you want to be a hematology nurse, you can figure that out later, or you can look it up on your own. But this is considered an adverse drug reaction, HIT, heparin-induced thrombocytopenia. So again, remember, if platelets are half of what they were the previous day, we're going to hold the medication and call the MD. So let's say the patient's platelet count was 300, and that's great. And the next day you go and check, and the patient's been started on heparin, and the next day the platelets are 120. Well, that's less than half. Half would be 150. That's less than half of what they were the previous day. So you would hold the heparin and you would call the MD and say, I did not give the heparin because the platelet count today is 120 and yesterday it was 300. And then we would take it from there. So heparin and Lovenox have a narrow therapeutic index. It requires 2RN check. And again, what should be checked? It basically should be certainly the 5 rights, and really you should be looking at the 10 rights that are listed in your book. Point of teaching for anticoag therapies, drugs. This can be the same kind of regardless of the drug, whether it's a platelet inhibitor, whether it works on the actual clotting system itself, the Clotting Cascade. But you want to have patients report burning, stinging, warmth, excessive bruising, swelling, or pain, because those are all signs of bleeding. You want to take Warfarin/Coumadin, same time each day. Again, you're taking 1 pill once a day, and so you want to keep those drug levels consistent. So if it lasts for 24 hours, then at about every 24 hours, we want to take the drug. We want to keep the patient anticoagulated. You want to avoid suddenly increasing your vitamin K rich foods. You don't want to go from having no vegetables one day to a ginormous salad the next day, because that could really change your INR, could increase your INR. Let's see. Report bleeding. So we already talked about that. We gave you examples at the beginning of overt and covert. And then avoid simple activities that could result in bleeding, like aggressive toothbrushing or using an old razor. We would actually recommend that people use an electric razor where there's less sharp blades, where the blades are hidden, they're inside. A woman's menses could be heavier, so we would want to assess for that as well. We would want to have them avoid strenuous or hazardous activities that could result in bleeding, and anything that could result in a blow to the head or the body. So here's some examples of those things. So we already talked about this, but I just want to reiterate that these are labs that you need to know. So you need to know what a normal APTT is and what a therapeutic level would look like. Same for, not for prothrombin, but for INR. Okay, remember PT is part of the INR. It's just a way that we report out a ratio of PT. Bleeding time, you don't need to know that necessarily, but liver function tests and the fact that those are important because livers make clotting factors. And so liver function tells us how well the patient's going to make clotting factors or not make clotting factors. And then a CBC, and we want to look at hemoglobin, hematocrit, and platelets. Clot busters, when would you use these? And the drug here is ANTIPLATELET. I'm sorry, there's no slide for it, but it is in your book. The big thing to know about ANTIPLATELET is, one, it is a clot buster. It will dissolve a clot, unlike heparin, unlike Coumadin. This will dissolve a clot. You would use it when you have an obstruction that is life-threatening or is causing a problem with venous access device. Okay, so could be used then, could be used even in a stroke. The risks are that it can cause significant bleeding, right? Because it's going to go in and break up clots. And if we have clots that are keeping something from bleeding and we break those apart, now we may have a problem, right? And here is a central venous catheter. We talked about this in class, how it works. I'm sure you could also YouTube it if you want to see. But a clot that develops inside, perhaps in here, maybe near the tip, can make this so that we can't infuse anything and we can't draw any blood. And that's the beauty of having this device, is being able to infuse and access the patient's venous system without poking them every single time. Okay, that is the end of anticoagulants. We talked about it in class. I've talked about it here. If you continue to have questions, please let me know.